Okay, cool. Hello, colleagues. Welcome. Just give us a couple of minutes so we can wait for more colleagues to join. Very pleased to have you today. One more minute and we will start. Thank you.
I
Okay,
think we
over
can
to
start
Sarah.
now. Yeah, thank you, Andres. I think we can begin right now. Good morning, good afternoon, and good evening to everyone joining us from around the world. My name is Sarah Ziksoka, and I'm an M&E specialist for social and behavior change. And on behalf of UNICEF Social and Behavior Change team, a very welcome to all of you to this global webinar on social and behavioral data segmentation and personas. We are very delighted to have all of you, our colleagues, partners, as well as practitioners across social and behavior change, monitoring and evaluation, and program implementation who are with us today. Over the next hour, we'll explore how data segmentation and personas analysis data can be translated into actionable insights that strengthen program design and delivery. We'll also spotlight some of our work that we've done previously and what we are currently doing. And we will also have some highlights from how countries are actually using this data segmentation for informing program implementation. And without further ado, I'll pass over to Helena Balesta-Bon, our social and behavior change specialist, as well as our capacity development lead, to share her opening remarks to set on for the session. Helena, over to you. Thank you.
Thank you, Sarah. Thank you, and welcome all to this very interesting webinar. I'm delighted to be here with you today. As Sarah was mentioning, I'm now in HQ with the SBC team on capacity development. But in another life, I was working with ESARO as an immunization focal point, SBC immunization focal point, to increase the uptake of COVID-19 vaccines and routine immunization. And while I was in ESARO, I used data from a time series community rapid assessment to undertake a persona segmentation analysis. And I wanted to understand with the team what interventions would work best with respondents who had different wealth brackets, because we knew that most zero-dose children were living in households that were facing multidimensional poverty. So the persona segmentation analysis helped us move from generic interventions that were focusing on awareness raising and risk perception to more targeted programming. For example, when dealing with population segments who were not able to save any cash or goods at the end of every month, receiving explanations from health workers on how to manage adverse effects following immunization was the most powerful interventions. But on the other end of the wealth bracket, with these populations that always manage to save goods or money or cash, the most important interventions were around injunctive norms, because thinking that family and friends wanted the respondents to fully immunize their children was the strongest driver to fully immunize their children. So this is just one example, yes, on how segmentation analysis can transform SBC from generic interventions to precisely targeted evidence-based strategies that reflect how people think, how they feel, and act within their social and economical environment. It embraces the fact that population and people are not homogeneous. And it also helps us understand or deepen our understanding of why people behave the way they do. This kind of analysis, the persona segmentation, enables strategic prioritization, focusing on interventions on groups that are most influential and most in need. It also facilitates monitoring within specific groups over time and helps connect individual behaviors with broader structural and social determinants. So I want to welcome you all to this webinar on persona analysis for SBC programming, where we will hear from real-world application of SBC evidence and advanced analytical approaches. So welcome again, and I hope you enjoy the webinar. Thank you very much, Sarah and team for organizing. Over to you, Sarah.
Thank you so much, Helena, for those insightful opening remarks and for setting the stage for today's discussion. Now, let me walk us through the agenda quickly and introduce our speakers for today. We'll begin with Gonzalo Talavera Folin, our data science consultant for social and behavior change. Gonzalo will lead us through the introduction to segmentation and personas analysis, and he will also share key findings from the faith communities for immunization work. Next, we will hear from another expert, Andres Esteban Ochoa Tawasa, who is also our monitoring specialist and the lead for the social and behavior change global M&E team. Andres will take us through the segmentation and personas analysis in the MPOX response, and he'll illustrate to us how data-driven approaches have actually enhanced emergency programming. From that, we will then move to country experiences from Uganda and Kenya. That is super interesting, actually. From Uganda, we'll hear from Tableba Chaita, the SBC RCCE consultant with the Uganda country office. And then we'll also hear from Ayub Duwel, the SBC officer from the Kenya country office. Right after that, we will have a Q&A session where we'll open up the floor for questions and answers. And right now, feel free to post any questions that you may have into the chat, as well as we can use the Q&A to introduce ourselves. Thank you. Over to you, Gonzalo.
Thank you, Sarah. And hello, everyone, and thanks again for being here with us. I am Gonzalo, and I work as a consultant in data science for the SBC monitoring and evaluation team at UNICEF. And I start with a very, very brief introduction to segmentation analysis and personas, and then I will share the first study we have done with these techniques using social and behavioral change data. Okay, so let's start talking about segmentation analysis and personas. And for the purpose of this webinar, we can define segmentation as dividing a population into groups. And what we're trying to do here is to identify and group together people who behave or think alike. And to do so, we need the groups to meet two basic conditions. The first condition is that members of a given group have to be similar to other members in the same group. And in terms of their opinions or their behaviors or attitudes,
And the second condition is that each group has to be different from the other groups. To show this in a quick example, let's say we have run a segmentation analysis in a study on social drivers of health decision, and as a result of this analysis, we found two groups: a group of people with high trust in religious leaders and skeptical of health workers, composed mainly by rural women of middle age, and another group who have high trust in doctors and nurses, who are getting their information mainly by radio and social media, and mainly composed by people from urban areas. So we now have two groups that meet our condition. Within a group, people are similar, and across group, people are different in terms of how they who they trust and how they get their health-related information. And what are personas? Personas are basically a fictional representation of an individual who represents a group. We create a fictional character. We give this character a fictional name and a fictional descriptions of the profile. So that way we can show the nuances and details of the group this persona belongs to. We can then use this fictional character, this persona, to explain how they behave and what could be driving their behaviors, who they trust, and use that profile to communicate results to different audiences. For instance, using the information from the little example I just gave you, we can have two personas based on those results. Fatou, a 35-year-old rural mother who trusts religious leaders more than health workers, and Abdi, a 20-year-old urban youth who trusts doctors and nurses and follows health information on the radio and social media. Having groups like this is very important for SBC, because this way we acknowledge that behavioral problems or behavioral challenges we are dealing with can affect people in different ways. So by doing segmentation, we can have many benefits. We can improve our understanding of people's experiences, desires, concerns, needs, and behaviors. We can identify the potential for behavioral change among specific groups. We can target the most promising opportunities for resource allocation. We can tailor services, products, and interactions to specific groups. And we can shape our communications efforts and community engagement efforts for awareness, engagement, mobilization, and uptake. Okay, so one of the ways of doing segmentation analysis is a statistical technique called latent class analysis, which is the one we have been using recently. We use latent class analysis for a number of reasons, but the main one is that it works great for discrete variables. Other segmentation techniques you may heard about, like factor analysis, for instance, work better with continuous variables. But in SBC data, we tend to have variables like agreements with statements, or questions like who you talk to when making a decision, or who you trust to talk about a certain topic. So latent class analysis is a great choice when we deal with variables like this. And latent class analysis can tell us a couple of interesting things. It can tell us if there are hidden or latent groups of people in our data, groups that engage in particular patterns of behaviors that can be easy to detect if we use the traditional way of doing cross breaks, like gender or age or location. Latent class analysis can also tell us how these groups are different from each other in terms of how they behave or how they think. It can also tell us how many groups we may have in our data. We can also know what the distribution of individuals across the different groups is. And we can also tell how what are the demographic characteristics of each of the groups. So let me share some real-world applications of segmentation and personas analysis. And the first study we will talk about in this webinar is a real example of a segmentation analysis done with data from a survey on faith and immunization, which we developed in the last year. And this was a study that was deployed in 10 countries from a mobile phone survey using a short quantitative survey using UNICEF's behavioral drivers model. And the study had the goal of investigating the influences of faith communities that could affect routine childhood vaccination. So let's go straight into the interpretation of results. I'll first explain how to read this plot, and then we will examine the results more carefully. First, we can see that in the plot we have 3 colored lines in the plot. In this study, we have identified 3 classes of respondents, or three groups. That is why we have 3 lines in the plot, 1 for each group. Second, while doing the analysis, we ended up with a set of variables that were the most relevant to help us describe the behaviors and opinions of each of the latent classes, or each of the groups. In this study, the relevant variables were 6, and are shown in the horizontal axis. These variables are having continued the vaccination of children during the pandemic, having vaccinated against COVID-19, considering vaccination as important, thinking that most religious leaders support routine vaccination, seeing their religious beliefs as encouraging vaccination, and thinking that leaders vaccinating publicly is an important factor for them regarding vaccination. So this is the set of variables that will be relevant to describe our classes. Third, in the vertical axis, we measure how likely individuals from each of the groups are to have answered yes or endorse each of the behaviors that we are showing in the horizontal axis. So this gives us a set of data points in the chart, and the position of these data points in the chart will help us describe the differences between each of the classes. So let's start analyzing each group in detail. Please first pay attention to the yellow line, or class 1, the first group we are analyzing here. The first variable we have from the left is having continued vaccinating of children during the pandemic. For that variable, we can see that individuals in class 1, this is the first yellow dot here, are very likely to have continued vaccinating their children during the pandemic. Above 80% of them have kept vaccinating their children during the pandemic. We can also see that most individuals in this class were vaccinated against COVID-19. This is the second yellow dot. And that most individuals in this class also consider routine vaccination as important. So until now, seeing these the first 3 variables, we can say that this class is made of individuals that are vaccine enthusiasts. And let's see what else we have in the rest of the variables. The fourth variable is in the fourth variable, we can see that most of the individuals in class 1 believe that the religious leaders in their communities support routine vaccination for children. And we can also see that members of this class see religious belief as encouraging vaccination. So if we combine these 2 findings, we in class 1 have individuals that are vaccine enthusiasts or vaccine supporters who additionally believe that their religious leaders are in favor of vaccination, right? So if we can put a name or a label to this group and call them something like vaccination supporters aligned with leaders perceived as supporters of vaccination. We also know from the analysis that this group is 52% of the sample, is a slight majority of the sample. Okay, so this is group 1. Let's compare results from the green group or class 2 and see how they are similar or different to individuals in class 1. The first 3 variables here are related to vaccination. Remember that they were continued vaccination for children, being vaccinated against COVID, and seeing routine vaccination as important. We can see here that most respondents in class 2 are much like those in class 1. They kept vaccinating their children. They have high vaccination rates, above 90%, and the great majority of them believe that vaccination is important. So in that sense, individuals in class 2 are also supporters of routine vaccination. However, in the next variables, we start seeing some differences. As opposed to individuals in class 1, individuals in class 2 are not as likely to think that their religious leaders are supportive of routine vaccination. And less than half of the respondents in class 2 believe that the religious beliefs encourage vaccination. So this class doesn't believe that religious leaders and religion are in favor of vaccination. They actually lean toward considering religion and religious leaders as opposed to routine vaccination. So if we have to come up with a name or a label for this class, we can call them something like vaccination supporters that are not aligned with religious leaders who are perceived as opposers to vaccination. And we also know from the analysis that this class represents about a quarter of the sample. So in total, we have around 75%, 50% from the first group and 26% from this group of the sample that are vaccination supporters, but their views on religion are quite different from each other. And that's an interesting nuance we can get from the data. Okay, let's finally look at the pink group or class 3. And we can see that this class is quite different from the previous one. First, they are not likely to have continued vaccinating their children during the pandemic. They are unlikely to have vaccinated against COVID, and they are divided about the importance of routine vaccination. So up to now, we can say that this class gathers individuals that are vaccine hesitant. And when we still see some differences compared to the other groups, individuals in this class are very, very unlikely to believe that the religious leaders support vaccination. And they are also very unlikely to see their religious beliefs as encouraging vaccination. So we can label this group as vaccine hesitants aligned with religious leaders perceived as opposers to vaccination. And this group is also around a quarter of the sample. So now we know that we have that there were 3 groups that were hidden in the data, and this is an interesting finding. We now know that not all the respondents that are in favor of vaccination believe the same about their religious leaders and religious beliefs. Some vaccination supporters are opposed to their religious leaders in their community, but others are actually aligned to them. And we can also identify that vaccine hesitants tend to agree with their religious leaders in terms of their stance on vaccination. Okay, so and there's a bit more to this I wish to refer to, and at this point of the analysis, we know which class each respondent belongs to. So we can use this class membership to explore the demographic composition of each of the classes. Very quickly, because we don't have much time, we can see. Remember that for this study we use the data from the 10 countries pulled together. We can see that in the first group, which is vaccine supporters aligned with the religious leaders, the yellow group. Respondents tend to be male from Abrahamic religions and mainly from certain countries, Kenya and Mali. In class 2, vaccination supporters that are not aligned with religious leaders, we have respondents more likely to be from Indic religions and to have higher proportions of Nepalese respondents. And finally, we have vaccine hesitants, which in comparison to other classes are more likely to have respondents from female and rural respondents and respondents from Iraq and Guatemala. So now we have a clearer picture of how religious leadership is related to vaccination. And we are now in a better position for programming or thinking about questions for further research. We can, with these results, we can choose to target people according to demographic characteristics in certain locations or with tailored interventions based on their religious beliefs. Or we can allocate resources to further explore what drives vaccine hesitancy in certain faith communities, or how can we leverage religious leaders perceived as vaccination supporters to increase intention to vaccinate. So this kind of nuanced insights turned out to be very useful for our programming colleagues, as they put them in a better position for leveraging the data to plan interventions or guide further research. So we replicated this approach in other studies. Well, I'll stop here, but in the next module, we'll be sharing another study, this time showing country-specific results using data from the recent Mpox outbreaks. Thank you again for your attention, and over to you, Sarah.
Super. Thank you so much, Gonzalo, for that overview and sharing the findings on the multi-country survey on immunization. Next, we'll hear from Andres, who will present the segmentation analysis of the global Mpox response. Andres, you're welcome. Thank you.
Thank you, colleagues. Thanks for being here. I also wanted to thank the colleagues from the section, UNICEF section, the monitoring immunization, who we did the previous study with. That was a study that was done across multiple countries using mobile phone surveys. I saw some questions about the instruments of the study. We'll be happy to talk more about it, so send us a mail, but we want to thank them to allow us to use that data that we're presenting to you. Now we're going to see another type of application of this analysis. This is specifically towards risk communication and community engagement. It is specifically in the response that UNICEF has been conducting towards Mpox, and how we have been using some quantitative data in order to create some segmentation of personas analysis to support programming. So here we use another version of the community rapid assessment that Elena was mentioning at the very beginning. This is the fourth CRA that we have done since the first one that was conducted during COVID-19. And it's an expansion that has been moving from the monthly immunization, from the response from COVID-19, and now we're using it towards bigger public health emergencies. It's a very strong approach in the sense that it allows us to reach between 1,200 to 2,000 respondents in this instance. We have information about those respondents on sex, age, and urban-rural setting. And we have developed not only a sampling frame that allows us to do national inferences in terms of the protective behaviors that we're measuring, but also to develop a weights model that has been tested and that applies to diminish and control the different biases that sometimes mobile samples bring. So in that sense, it gives us a good picture at a cost of a fraction of a full study on what are the use of protective behaviors. If you would like to know more about the methodology, or if you are from other colleagues from other sections, we can always discuss on how we could implement this or support the use of this type of approach. Protective behaviors, these are going to be the ones that we're going to be seeing today. These were the specific 6 that were measured on this instance: avoid close physical contact, do not share personal items, hand washing, whether or not people are regularly checking their symptoms, if they're not informed, if they have informed or not, and they're monitoring their children and symptoms on the children, and if there is isolation of affected individuals. Additional to this, we're also taking into consideration whether or not respondents will be taking a vaccine if available in some of the countries, but not in all of them. So what happened when we saw the segmentation analysis? So this is one of the cases in one of the countries that we use it. This is in the DRC. When we did the segmentation analysis here, you can see that we have two classes, right, or two groups. You have one group that has a higher practice of some of the protective behaviors and another one that doesn't. So that gives us two profiles. The first profile, the one that is on red, it tells us there are individuals that are unlikely to discuss the ways to protect themselves in the household. They are also less likely to that the other group to follow other protective behaviors, and they are also following less other practices. They tend to be 51% of the sample. This is important because it let us know that it's not a small minority, but it's also a significant part of the respondents. The second group tell us that it's individuals who are likely to follow the protective behaviors, who are discussing mpox in the household particularly, and checking for symptoms and hand washing regularly. You can see in particular the differences between groups here. There are significant gaps in some of the practices, and this is where the differences between groups are the greater. So when we're thinking of programming, looking at these gaps, it's going to give us greater benefits concentrating on one of the groups than the other. Where we see that there are small gaps, like for example, in this instance, checking for symptoms regularly, or where we say if they look for care and have symptoms, then we're saying that there is a common practice on the population. There's a high practice here, and there is a low likelihood of the practice here. So we want to look there a more wider approaches to the population that will allow us to either target more, to expand the approaches and to concentrate more on some specific either community engagement activities or to have a more targeted communication. When we look at the second part that Gonzalo was mentioning, now we're going to be looking at the demographic parts of class membership. So what are we seeing here? Who are the people who are more likely to be following protective behaviors based on some of the demographic characteristics? We see one of the variables that we used to see this was the language that people used to respond the questionnaire. This we use as a proxy to understand where people are more likely to be responding from, the demographic, the geographical area, as well as likely possibly belonging to specific groups. We see here that people who responded in French are 1.8 times more likely to be following protective behaviors. If you are from a city, urban respondents are 1.4 times more likely to be in the following protective behaviors class. However, here's a very interesting point that the data tell us, that even though you are from a city, if you are from Kinshasa itself, you are less likely to be following the protective behaviors. So cities, other cities that are not Kinshasa, respondents from other cities that are not Kinshasa are more likely to be following the protective behaviors, but if you're responding from Kinshasa, it appears you are less likely to be following it. So this allows us to see that if we are looking to an urban response in Kinshasa, we might need a more targeted or more specialized message than compared to for the other cities. We also see, for example, here that older individuals are more likely to follow protective behaviors, and that the males are 24% less likely than females to be in the following protective behaviors class. These are important because this confirms some of the observations that were seen on the ground through qualitative observations and reports. And it tells you also the importance of triangulation. It's always important to take any of these approaches not on isolation, but to combine with data that we're observing in the field, reports from implementation, and at the same time from more representative data from the population as this approach. Now, we're soon going to be hearing from our colleagues from Kenya and Uganda. So I just wanted to quickly show you some of the elements that you can see regarding those countries using the same surveys, the same approach. In Kenya, we can see that there is some gaps in some of these specific behaviors, as we mentioned before, and the same in Uganda. There are some similar patterns, but the gaps are different depending on the country. So I will let you peruse the slides, and if you have any question specific on what you see on the screen, please let us know on the chat. The same thing on Kenya and Uganda demographic effects on class membership. We only selected a few facts for you to see the use of the approach. For example, here it allows us to see we had enough evidence to look at the geographical areas of the country, and we saw that for example, in the districts of Busia and Taita Tavera, it was 1% times more likely to be in the protected class than those in Nairobi, for example. And then the same with if you are from Callado, you're 33% less likely to be in that class. In Uganda, we saw very interesting about the ages being one of the most relevant predictors for following protective behaviors. And seeing here, you can see like the different likelihoods that you can see depending of what age group you are having and using. And again, this is very useful when we combine with our data, and this is the last part I wanted to share with you. This is something that we have done once we combine the previous with the regular results of the survey, plus observations of the field, plus discussion with practitioners. We select some of the key findings that are appearing on each one of these rounds, and then we submit these to consideration for example, the RCC committees in a country or the National Health Authority to discuss the next steps forward. In this case, we were highlighting the use of the segmentation analysis was put specifically in this section. People unaware, younger male and urban are more at risk, and it allows them to specifically create something that we have been using on this MPOX response, which is the behavioral journey. This is the behavioral journey in Uganda, and it tells you it's a very basic representation, but very impactful in the sense that it lets you see the key behaviors, the overall average response, and then how this is moving between rounds. And then what is the causal pathway? If people are or not self-checking themselves on their skin for symptoms, then a person or not might find out that she may have mpox. If a person thinks that she may have mpox, then this will lead to that person to seek care, then to the confirmation of the mpox. And if the person has mpox, is to follow isolation and treatment and to avoid other contact. So in this sense, we see that these behaviors are high, but the bottleneck to stop this behavioral journey to protect someone starts here. If we don't have a self skin check or a family check, then we're going to be missing a lot of the population that could then follow the other protective behaviors that they are already consciously thinking about. So this is a useful way then to put the data and then to confirm where we could be taking a closer look at. So I'm going to hand it over back to Sarah. But again, we want to thank you all. And now with the data we just presented, also thank our colleagues in the public health emergency section, who also has worked with us in this project and who has allowed us to use this data today. So thanks.
That was very nice. Thank you, Andres. Without further ado, we will move to the evidence used by the countries. And we are featuring two countries, Uganda and Kenya. And Uganda will go first. So on this note, I'm pleased to invite Table Vachaita, the SBC RCCE consultant from Uganda. Welcome, Table.
Yeah, thank you, Harriet, and thank you, colleagues on this call. I'm just going to share some experiences on how we utilize this data, and of course, we are very grateful and appreciative of it. Next. Now, one of the key findings that we found interesting, we just picked a few, which we want to share with the team here. We realized that there is low level of daily symptom checking, with only 33% of respondents reporting that they monitor mpox symptoms regularly. And the other one, we also realized that the household discussions about mpox was limited. You can find that the number is very low. Of course, this is reported. Only 41% of respondents reporting that the topic is discussed at home. So you can see maybe there's some bit of stigma. They don't discuss it a lot. Everybody suffers locally, quietly. And how did we use the data which Gonzalo and team and Esteban have generated as a country? So what we did, this segmentation provided a deep understanding of behavior patterns along the mpox prevention and care journey. The insights were used to, first of all, to triangulate findings with existing social listening and community feedback mechanisms, ensuring that the intervention design is informed by this evidence and is context specific. So as a country, I've been also doing some other studies, anthropological studies, ethnographic studies, and community rapid assessments. So this was a good information that came in to triangulate to really zero down on the actual issues which we have been able to respond to. We're also able to inform targeted behavior messaging, particularly promoting daily symptom checking at household level and reinforcing alert-seeking behavior, because that was a key challenge in the earlier days of an earlier month of the outbreak. The behavior journey product provided the prioritization of audience segments, helping to tailor messages and delivery channels for greater impact and community engagement. At the different points, as Gonzalo was showing you, would just understand what happens at this level, and then we tailor messages and approaches accordingly. Then our recommendations to colleagues on this call who have not maybe utilized some of these approaches of segmentation, please, this is what we have to say. The segmentation analysis offers valuable insights into behavior journeys. However, I recommend that the practitioners also focus on outliers, those whose behaviors deviate from the advised journey. These outliers often reveal hidden barriers, beliefs, or even contextual realities that mainstream patterns may overlook. For instance, I may cite an example here. Among respondents who thought they might have mpox, only 89% said that they would seek care. So what influences the remaining 11% who don't seek care? And we all know that if with the mpox, if you don't seek care, you are not isolating and you are keeping cover, it means whatever method you are using, you are able to spread to spread the disease further to others. Of those who tested positive, that is 70%, would isolate with actions. So what other actions do the 27% take instead? Like I've been discussing that one. So what do they do? Do they hide? Do they continue with their way of life, spreading the infection on the formites, on the clothes, and utility they use in the home? So we need to do to really handle that one. And so one of the things which we propose is that this deep understanding enables practitioners to design more inclusive, context sensitive, and uh, uh, and effective interventions that address the full range of community behavior. So we feel that it's very important to look into these outliers, because numbers alone cannot, the 27, the others that are outside the people who are doing the good practice, there's always need to find out what are they doing. So that's why we sanction ethnographic studies, anthropological studies, so that we get a clear, deep understanding of what is happening. So this is what I had to share with my colleagues on the Ghana team, Miriam and Patrick, who are on call. Over to you, Harriet. Thank you.
Yeah, that was very nice. Thank you so much, Kable. And now I'm going to usher in Kenya Country Office. And Ayub, you're most welcome. So Ayub is the SBC officer in the Kenya Country Office. Over to you, Ayub.
Thank you, Harriet, and happy to have this opportunity. Colleagues, greetings, wherever you are. Mine is just to take you through also the Kenyan experience in response to the Mpox outbreak. And to start with, one of the key things that our country has been sharing quite frequently is the situational reports of Mpox. And majority of our Kenyans that were some of those who were affected or confirmed to have Mpox, the majority of them were on home-based care. So when this survey led by our HQ colleagues and Geopol team did this, the results that most surprised us was that the household level discussions on Mpox was very low. And again, among the different groups that the survey was done on, it was even low among the sex workers. So as you know, Kenya is one of the countries that we have a very high population of youth who are very conversant and usually use a lot of social media. And we thought as a highly verbal community, we will be able to discuss anything. And this is the findings that household members level discussion was low was one of the really surprising thing that we needed to act on. So one of the ways that now we used this evidence and to improve on household level discussions was one to look at how can we talk more better with our sex workers. So the finding here was we got to dig deeper into our analysis, and we had came to understand that our sex workers, some do different occupations. There are those who will go with truck drivers all the way from Kenya to other places, and those are one population that we really need to speak with. And then some who work at night in hostels, bars, and eateries, and they are the ones who have children and who will usually stay close to truck stops, and therefore this is where they can be found. Now, with this kind of segregation, and our idea was just to improve household level communication among those who are on home-based care, we came up with the idea of planning for the upcoming Mpox vaccination at that time that was happening. So before then, we looked at who is better to communicate at household level. So instead of the usual community health promoters we have, we went ahead and recruited, sensitized a different group whom we call the peer educators for this group. So when we deployed them at different times. So depending on the segmentation that we had, we came up with a social mobilization team that works at night, really to go after those who are available at night for hostels, bars, and eateries places, and then others who work at truck stops. This moonlight social mobilization and these other different strategy we use for this group really bridged the gap, and we were able to vaccinate quite a number because we only had 10,000 doses, which cannot reach everyone, and we need to be targeted. And since few are speaking about Mpox at home, then it was very hard to know who to target better. With this approach, we really managed to target further and reach the key population that we are targeting for the campaign. So our key recommendation for the colleagues in this call and who are hearing us, use of data is very important. And as well, the other important thing is to look at how supportive supervision is happening at all levels. Because with this, you may understand even if those discussions are happening at home, in home-based care, what is happening, how conversant are the other household members on Mpox and how they can protect themselves. And then it can give you really to change your strategy on who to deploy. Is it the normal social mobilizers or peer educators, and who is going to really empower communities to prevent the spread of Mpox or any other diseases. So that was the journey of Kenya around Mpox. Over to you, Sarah.
Thank you so much, Ayub. That was super interesting and insightful. Thank you, Uganda and Kenya, for sharing your insights about Mpox and what the programmatic implications actually meant from the segmentation data. Moving on, as we almost close, we shall now move into the question and answer session. And this session is going to be moderated by our own Rebecca Smith, an SBCM and e-consultant. Becca, over to you. Thank you.
Hi, thank you, Sarah. So I think we've had some really great questions so far in the Q&A here. And I think perhaps we could start with the comment that's at the top of the Q&A right now from Etienne. Andres, you've provided a response, but perhaps I think it would be great to touch upon the question here about the framing of personas, defining by behavioral traits as opposed to a bit more kind of personalized profile. Do you want to just add anything onto the explanation that's already in the chat, or Gonzalo as well? Either of you, please feel free to jump in.
Thank you, Becca. Yeah, we please, colleagues, if you have questions, put them in the Q&A. It's very useful for us because then we later compile and we create frequently asked questions based on the questions we receive in those section, and it's easier to then polish the responses. So feel free to ask any questions there, even after the webinar. So yes, I think like what Etienne is asking is very important, right? So how do we move to the personas part? And one of the responses that I was trying to provide there is so this data, first of all, let's never take the data in isolation, right? So let's always try to do data triangulation from what we're seeing in the field, the reports we're having, from the implementation itself. So then we make sense out of the data. Sometimes we're going to have contradictory findings. So how do we make sense of these findings? So that's what's important, to have a multidisciplinary approach. Why am I mentioning this? Because I think like the personas analysis is a very specific and strong approach that is most useful when we're working with behavioral scientists. So for example, we on the global monitoring team, we are more data scientists and monitoring specialists. So we wouldn't feel as capable as a behavioral scientist to develop the personas analysis. So once we try to move to the personas specific definitions, we will work with a behavioral scientist and try to understand the combination of the data, the best way and approach to build that specific persona, and the best way to communicate it. I think that there are specific approach to use it depending of the areas of work. There are more or less established, I think, guidelines as well, depending on the type of communication, even what type of personas have been used in the past. We, for example, with my team and with Becca specifically, we had worked in the past with personas for harmful practices. So it's a very good approach that always to have that the support of behavioral scientists. So bottom line, let's combine the data, let's see the data together, and let's work with those better positioned and also with the practitioners on building those personas. That would be my recommendation at this stage. Over.
Great, thank you so much, Andres. And we have a couple of questions I thought maybe we could bundle given the short time. First, around the possibility for doing segmentation analysis if you only have qualitative data. And then also there, I just wanted to note as well, Gonzalo has provided a link or a reference for a paper that that specifies the package that was used to run the latent class analysis in R. Because someone was asking, we have a question here, what software can latent class analysis be run on? Usually run it on R. So if you're interested in getting into a deeper methodological discussion, you can see the paper there. So I'll hand it over, either Andres or Gonzalo, if you'd like to touch on those points about software options as well as segmentation analysis using qualitative data.
You can go, Gonzalo.
Thank you. Yes, regarding software, we have used a package in R, which is called Polka, P-O-L-C-A. I have put the paper that explains the package and how to use it in the Q&A and in the chat. The advantage of those is that R and Polka are open source programs, so they are free to use. They require a little. There's a learning curve to those, but it's free and can be used by everyone. There are other packages and that can work in Python and other specific proprietary packages and tools that can be used for latent class analysis, like M+ or latent gold. But we have stick to R, so we can make the results reproducible with a script and use it in different projects. We have worked with mostly with discrete variables in the examples we have shared with you. We have not worked with qualitative data doing specifically a latent class analysis. There are some ways where you can take some findings and try to make them like more quantitative, like so you can include them in analysis. But as Andres mentioned, I think the key of a tool like this is to use it as an input for triangulating the results with other results you may get. Segmentation analysis has worked great also to identify opportunities for qualitative research in specific groups of people where we need to know more about how behavioral drivers work and or how to explain some behavior. So I would say that triangulation is the most important thing we can do to get the most of the results from latent class analysis.
Yes, and if I may add here, thank you, Gonzalo, because this is something that comes to my mind now that we're talking about it. So the useful thing about this kind of data is it can be useful for formative research, whereas informative research is going to give us a profile that we're going to start thinking about what we're seeing on the thing that we want to study on the ground. But it can also be used for monitoring, where we see like the changes over time. For example, with the MPOX, we're using it a little bit in monitoring as well. But then I see some colleagues from evaluation. It can also be very useful from an evaluative perspective, in the sense of analyzing if the response itself is addressing some of the things that the data is telling us. But how can you combine the different tools, qualitative and quantitative? This is a question that sometimes we don't take enough time to respond. For example, if you see that there are certain elements present in certain groups based on the segmentation analysis, then you can change your, if you have focus group discussions, and then you use the focus group discussions guides to go into the areas that you see the different groups have particular behaviors. For example, if you see that age is a difference and older people have less trust, as we saw on religious leadership, and we're doing focus group discussions on the religious communities, well, let's then, when we're doing focus group discussions with all the respondents, ask them more questions about that specific area. So then we can find the causal mechanisms behind that. So once we understand the causal mechanisms in that way that are very specific to that group, then we can address them with specific community engagement processes or with specific messaging as well. For example, this is also applicable. We're doing some human-centered design. So I was just thinking on a way of thinking how to combine it, and one possible way is that, but at the same time, I wanted to touch on other uses because we didn't get to that part. But in any case, thanks. I wanted to complement what Gonzalo said.
Great. Thank you both so much. We're coming to the end now, and I just wanted to mention, as Andres said, you can still add more questions if you have any follow-up. Put them in the chat for the meeting, even after the meeting ends, and we will compile a kind of info sheet in response to the different questions and make that available. So please feel free to continue the conversation, and I'll pass it back to you, Sarah.
Thank you so much, Becca, Gonzalo, and Andres. I'll pass back to Andres to do the closing remarks, as well as some key questions that he would like to pose to the audience. Over to you, Andres.
Thank you, colleagues, for being here with us. This is one of the efforts that we're doing with SBC to strengthening the field through the work on evidence, also strengthening the work on monitoring, and how it also this will feed into stronger evaluations and a stronger case for what we do, which is social behavior change is useful, can accelerate results about the different areas of programming where it supports, and also how we can, as a sector, and not only as an organization, keep getting better at our work with evidence. We wanted to share these questions with you. If you have work on segmentation analysis, let us know. If you at any point would be more interested on this, also let us know. What areas can you see these are useful to be used as well. We're currently conducting some trainings on this specific approach, for example, for Africa CDC. If there are other opportunities that you may see with your governments or with the other organizations, we're also very happy to think of that part of the capacity building, and capacity strengthening agenda. But if you have any questions, now we go to the last slide. Please feel free to reach to me. Thank you again for all your attention. We hope it was interesting, useful, and we hope to hear from you. And have a wonderful day, evening, wherever you are in the world. Thanks.
Bye. Thank you, everyone.
Bye-bye.
Bye.
And congrats to the team organizing. Thank you, Sarah. She did a wonderful job.
Thank you. I'll end the event now. Have a good morning, afternoon, and evening.
Yeah. Thank you all.